Hello. Hey guys, am I audible? Am I visible? A very good evening, everyone. Hope I'm audible and visible. If so, say me hi and a hello. I know I still have to take FARRE of endocrine and skin and GIT. I'll definitely take that. And so, since
Hey guys,
you've
am I audible? Am I
completed
visible?
with your microbiology practicals and pathology practicals, what we thought is like we will take time to look at the slides, right? In my YouTube channel, I have put a few gross images how to answer them for Viva, and this is for slides, right? So primarily, I am by this time tell how many of you know the slides by heart. Hi, really, Rizaline. You must have known the number slides by heart, right? Broken left corner, 0, 1, appendicitis. You must have definitely known that, right? So I will definitely help you to identify the slides also, because as a pathologist, I feel that you have to look into the microscope to diagnose and not outside the microscope to diagnose. That's my first thing. Second, what are the questions which can be asked? Because most of them are like a OSCE pattern. They give you a clinical history and then they give you a slide. If it's given, great, easiest way, because you can correlate them and come to a diagnosis. If a clinical is not given and you have tried a short note on how did you make a diagnosis, or if a Viva happens, how do you make a diagnosis? These are some things which I expect from an undergraduate. That's what we're going to discuss today, right? Ready? I'll ask you questions as usual, because you're in the fag end of pathology sessions. I am sure you will be able to answer much more than others, right? Okay. First thing here is a simple slide of iron deficiency anemia. So what I want you to remember is PW Meded has digital slides. I hope you must have explored that. If not, I'll tell you how to explore that. We'll look at iron deficiency anemia. I want you to look at the Viva questions. We'll discuss them and also look at the slide, right? This is an image. It's not a digital slide. This is just a simple image. Can anyone tell me how will you call it microcytic? That's my first question. How will you call it microcytic? How will you call it microcytic RBC? This is a very common question. As a pathologist, I want an undergraduate to know, right? The easiest way to call it microcytic, most of you will know. If not, it's important to know that you have to compare it to the size of the small lymphocytes nucleus. If an RBC is smaller than the nucleus of small lymphocyte, I call it a microcytic RBC. I'm sure most of you know that, right? Definitely will know how to identify it as a microcytic RBC, right? So like I said, Meded slides, right? This is the Meded web version, or in the app version, you have something called in 3D library. Inside that, we have digital slides. All these are not images, these are slides, real slides. What is there, what we see under the microscope, right? Now let's go and have a look at the IDA slide. Let's zoom it. Let's zoom it. See, almost you see nothing there, right? So now you zoom it. You see almost every RBC is very tiny, right? Yeah, very tiny RBCs. The most important thing, it's not just tiny RBCs. They are microcytic. I know that for sure. You know that for sure by comparing the size, right? I have an WBC here. Maybe not a lymphocyte, but the neutrophil, but definitely way smaller. That's the first finding. You have microcytic hypochromic RBC. Look at the slice. It's very thin. Okay. Fearless flame, I'll definitely come to it. When we talk about CL, I'll talk about that, right? It's very thin rim of hemoglobinization around. There's so much of pallor. Especially, look at this cell. It looks like there's only a very thin rim of hemoglobin. Rest everything here is pale, right? The extremes of pallor. When a pallor is more than central 1/3, I call it an hypochromic cell. When a cell is smaller than a small lymphocyte, I call it a microcytic RBC, right? Not just that, there's a very important clue to call a microcytic hypochromic RBC is a pencil-shaped RBC. Look at that. That's a beautiful pencil-shaped RBC. It's elongated, thin, elliptical like a pencil, but again, it lacks hemoglobin. These are important clues for me to identify. Okay, it's a microcytic RBC, hypochromic RBC, and it's pencil-shaped, right? I'm sure you must have used these two terms. Okay, you must have used these two terms. Anisopoikilocytosis. Can anyone comment what do you mean by anisocytosis? Fine. Krish, we'll meet soon. This is for your seniors, second year exam going. We'll meet soon for sure. Fine. This is anisocytosis, change in the shape of the RBC. Some may be bigger, some may be smaller. Poikilocytosis is change in the size and the shape of the RBC. Size anisocytosis, shape is your poikilocytosis, right? So you have to know an iron deficiency anemia can definitely have anisopoikilocytosis, right? These are real life slides. They're in the Meded app. Please use them whenever required, right? Now let's go back to our PPT. Fine. So what are the questions we can ask, right? Identification point and size. Like I said, this is important. You have to know it. This is important. You have to know it. If it's more than central 1/3, I call it an hypochromia. Normal 1/3 having pallor is completely normal. More than 1/3 is hypochromia. You'll have anisopoikilocytosis. pencil shaped is very, very, very characteristic of iron deficiency anemia. Fine. Perfect. I'll ask you a few questions. I want you guys to answer. Let's see if you'll be able to answer that, right? Any causes of microcytic hypochromic anemia? I'm sure you know the mnemonic Sitama. I am not interested in the mnemonic. I want the causes in the order. The first thing is definitely iron deficiency anemia, thalassemia. If you answer these both, I'm very, very, very happy. Iron deficiency anemia is definitely one of them. Thalassemia is definitely one of them. Sideroblastic anemia is definitely one of them, right? The anemia of chronic disease, I'll put a star mark here. They do have microcytes. Microcytes will be there, but they are not microcytic anemia, they are normocytic anemia, because normal cells also will be there, microcytes also will be there, it will be combination, right? Iron deficiency, thalassemia, major, minor, sideroblastic anemia are classical cause of iron deficiency anemia, right? Or your microcytic anemia. Fine, perfect. Inside Sita is great. I don't, but I'm person like sideroblastic is something to be told last. Iron deficiency is first, thalassemia and second, in the same order, right? Perfect. Now I'll ask you one more question. If you have to tell, okay, it's a clinical history, what history or what nail change you will see in case with iron deficiency anemia? A very classical nail change, and I'm sure you must have definitely seen that, read that. A very classical nail change, that is koilonychia. A spoon-shaped nails, koilonychia, is very, very, very classical for an iron deficiency anemia. Spoon-shaped nails, the convexity of the nail, very classical, right? At the same time, in children, pica, it's not classical for iron deficiency anemia, it's classical for any deficiencies. Nutritional deficiency, they start to eat inedible objects like chalk piece, like dust, like the wall, the paint. They try to consume them, eat inedible objects. That's pica. That's also very classical finding for children in case of an iron deficiency anemia. Fine. Okay. What is the most sensitive or the earliest lab finding which will be changed in case of iron deficiency anemia? What's the answer for this? Most useful parameter, most sensitive lab test, the first test to be changed in case of an IDA. What is the answer? See you soon here, Paritosh. The answer is simple. It is serum ferritin. Serum ferritin is by default the most common finding, the most earliest finding, most earliest change which happens. And yes, after treatment, I'll have to increase the dose of iron even for some more time, give dose of iron, so that serum ferritin becomes normalized, because the stores needs to be normal by default, right? Perfect. How do you differentiate iron deficiency anemia and thalassemia on a peripheral smear? There are multiple ways to differentiate IDA and thalassemia. This question is very specific. How do you differentiate on a smear? I can differentiate it based on CBC, and also I can differentiate based on smear. Can anyone tell me how do you differentiate based on CBC first, then we'll go to smear also, right? Amazing, guys. Great insight, great Sampreet. On a smear, iron deficiency anemia will have the pencil-shaped RBC more towards it. Microcytic hypochromic will not be able to help me to differentiate. Anisopoikilocytis will not help me to differentiate. Thalassemia will have target cells, very classical for thalassemia. IDA might not have unless a very, very severe case of IDA, right? Normal IDA might not have target cells. NRBCs will be there in more thal major. I won't have that, right? Not teardrop, target cells, right? So IDA shows anisopoikilocytosis, pencil-shaped RBCs. Thalassemia shows target cells, okay? Targets is more classical, great insight. CBC wise, it's much more easier for me to differentiate based on two values, RDW and Menster's index. See, this is where it gets tricky. The moment you answer something new, the Viva will go on asking like, what do you mean by RDW? What do you mean by Menster's index? And what is the difference? You answer more, you'll get more questions. If you know the answer, please go ahead and answer confidently, right? And the easiest way to remember what happens in RDW and what happens in Menster's index, right? Though it's not the right way to read, but I can say thalassemia. RDW will be narrow, okay, in case of a thalassemia, and Menster's index will be less than 13 in case of a thalassemia. Fine, okay. Ashi, we'll definitely inform it at the earliest soon, okay. This is for your seniors. We'll definitely take care of you in a few days. Fine. Okay. That's the first slide. Few important features. If an IDA slide comes in an exam, to write in the exam paper, and if they are going to ask a Viva regarding iron deficiency anemia, this can come handy literally. Fine. Perfect. That's about the first one, right? Similar way, we look at one by one slide. I have a set of slides today, and we have a set of slides tomorrow, so that we'll cover major topics, be it in Viva or in practical exam. It will be useful for sure, right? Great insight. Megaloblastic anemia, right? Can you look at the slide first? Then we'll come to this. Before going to slide, what's this finding? I know everyone knows the finding. Comment on the finding. Let's make it more interactive. I'm going to the MedEd app. MedEd app has a real life slide of megaloblastic anemia. You go to the digital slide selection in the 3D library. You go there, it will be marked. It's an hypersegmented neutrophil. It's classically been marked. If you zoom in, look at that. Can we call it hypersegmented? Definitely, right? Look at the number of segments. There are so many, right? There are so many segments. Look at this. There are so many, right? If you can count here, there's like 1, 2, 3, 4, 5, 6, easily more than 6, right? So I call it a hypersegmented neutrophil. That also is there. International criteria is slightly different. Indian criteria is slightly different. Books differ, right? 3 to 5%. If it's more than 5 lobes, and among 3 to 5% neutrophil, I call it hypersegmented, or even a single neutrophil. Here I have this neutrophil has more than 6 lobes. 6 lobes. That itself is enough for me to call it hypersegmented, right? More than 5 lobes or 6 lobes is enough for us to call it hypersegmented neutrophil, right? Great insight. Okay, perfect. So now let's go back to the questions. Let's go back to the Viva questions. You're going to answer that, right? What are the identification points in a slide for us to call it an megaloblastic anemia, right? I have hidden the answer. I want you guys to tell the answer. Then let's go and look at the answer. Identification points for me to call it a megaloblastic anemia. 2, 3 is more than enough for me. When I say megaloblastic, the first thought is it's a subtype of macrocytic anemia, right? Obviously. So the first finding is the RBC finding. Do not jump to WBC for the only reason anemia is an RBC related disorder. I'll look at and talk about the RBC first. I'll have macroovalocytes. That's the first finding. You'll have macroovalocytes. Anisopoic will be there, but that's not something which we focus on, right? It will be there. We'll ignore this for now, but yes, definitely will be there. Hypersegmented neutrophil also will be there. This is the earliest finding in case of an IDA. This is a very specific finding in case of an IDA. Fine. Okay. It's a very specific finding, hypersegmented neutrophil, and macroovalocytes is an earliest finding in case of an megaloblastic anemia, not an IDA, right? Yes, RBC number will be reduced because megaloblastic anemia will not let your bone marrow proliferate. It's no nutrition, right? It will not proliferate much. So obviously the RBC number will be reduced, right? Can anyone tell me the causes of megaloblastic anemia? Not a difficult question at all. Cause of megaloblastic anemia? There are only 2 causes, right? You know that for a fact. If you have a Viva, they'll definitely ask you how do you differentiate them as well, right? I have 2 causes, B12 deficiency and folate deficiency are the cause of megaloblastic anemia, right? I just want at least 2 pointers clinically and on examination or history wise. How do you differentiate B12 deficiency anemia and a folate deficiency anemia? Just 2 pointers. Might definitely come in a Viva. B12 also is folate. How do I differentiate with the help of history and examination? Sure, inside, I'll tell for sure. Okay. B12 will be seen in vegan people. Folate deficiency will be seen in people who consume less fruits and greens. Because the moment you cook a food, folate dies. So once you consume fruits, which is edible without cooking, folate lives for a longer time. Yes, you might consume meat. Doesn't mean that you'll have enough folate because folate is very heat labile. It will be destroyed on cooking. Do remember them, right? And perfect, like Inside said, I'll have neurological deficits here. The neurological symptoms will be present here. It will not be there. Just like an altered vibration sense, altered sensation will be present in B12 deficiency, will not be present in folate deficiency, right? Minimum 2 features to differentiate B12 versus folate deficiency. Fine, perfect. Why do you call it and why do we see hypersegmented neutrophil? It's simple. The name says megaloblastic, right? So the blast is very big. The nucleus is very big. So obviously when it lobates, the lobes also will become very big. That's all right. It's due to defective DNA synthesis, abnormal DNA synthesis, actually nuclear cytoplasmic asynchrony, and I have nuclear maturation abnormality. Inside you ask me a question, I'll link it here only. See, nuclear maturation is defective in case of hypersegmented neutrophil. So can I say in this condition, RBC nuclear maturation also will be defective? Yes, for sure, right? So when you take RBC also, I'll have a defective nuclear maturation. If you remember RBC's erythropoiesis, right? The pro-erythroblast has big nucleus. When it came to an RBC, entire nucleus was disappeared. It was gone, right? So maturing of nucleus in RBCs, disappearance of nucleus, because mature RBC does not have nucleus. So there are possibilities for me to retain some of them, right? So if I retain the nucleus, right, nuclear maturity defect is nuclear fragments can be retained. One of the best example for that is basophilic stippling. Basophilic stippling will be present here. That's a nuclear maturation defect, right? At the same time, you'll have Cabo ring. That's a nuclear maturation defect. So the stippled RBCs are defects in nuclear maturation, right? At the same time, even in normal, when my bone marrow is performing very good work, right, there's a possibility some of the remnants might stay back. So who will remove the remnants? My spleen will take care of the remnants. So in a place where spleen is not functioning, I might have a little bit of nuclear remnants there. That's what Insight asked me. That's an Howell-Jolly bodies. Howell-Jolly bodies are basophilic inclusion body seen in H&E, seen in the Leishman stain. These are seen in conditions where there is no spleen, asplenia, or as a part of a treatment, we do a splenectomy. Because normal spleen will take care of the controlling part. Tiny errors are there. I will remove them so that RBC stays purely without nuclear elements, right? So if spleen is not functioning, I will see the nuclear remnants there. That's a Howell-Jolly body. Fine? Clear? Perfect. So one of the best way to differentiate B12 and folate deficiency is neurological manifestation. Will be there in B12, will not be there in folate, right? I'll zoom out. The slides are there in the Meded app, in the digital slide section, under the 3D models. Please go and have a look at them if you want to see a real life slide. Otherwise, image is good enough for you to identify as well. Fine. Next one. Simple question. Can anyone tell me the diagnosis? I'm sure you must have seen the diagnosis, but still, can you tell me the diagnosis? What's the diagnosis? Anyone? The simple one, right? First of all, is it a blast? Not a blast. And I have told you in lectures how to identify a blast easiest way possible. If you see a cell which is 2 to 3 times the size of an RBC, I call it a blast. This cell is definitely 2 to 3 times the size of an RBC. This also is definitely way bigger, right? So it's a blast. If it's a blast, I'll think of a leukemia, right? Acute or chronic, right? And here, if you see, these blasts has tiny bit of granules. It has good amount of cytoplasm, good amount of cytoplasm. Whenever a blast has good amount of cytoplasm and a little bit of granulations, we'll call it a myeloblast, right? So most likely myeloblast, most likely acute myeloid leukemia. We look at a myeloblast in slides, in a real slide, right? We have slides of acute promyelocytic leukemia. I hope that will help us to identify the myeloblasts. Acute promyelocytic leukemia is actually a variation. You tend to see the buttock-shaped cells. We keep reading buttock-shaped cells, right? This is a real buttock-shaped cell. That's how it looks like. Okay. Can you see that there's a tiny inclusion here? That's an OR rod you can see there, right? Okay, you can again see a cleaved cell, a buttock-shaped cell. Fine. All these cleaved nuclei are called as a buttock-shaped cell, and we have your tiny granules and thin rods. Those are the OR rods. There are so many cells which are cleaved here, right? There's a classical appearance of an APML or an acute promyelocytic leukemia, right? So you have blast, you have atypical promyelocytes, all of them can be seen in case of a leukemia. Fine, perfect. Now let's go to the pointers. I'm not sure how your college does the practicals, but generally if it's a blast, we tend to focus them for the students because it might be difficult for them to identify here and there. So if it's written that do not move the slide, which means it's a blast. I have focused an OR rod or I have focused a lymphoblast, a classical finding, right? Pointers, there are numerous circulating blasts. The moment you say it's an acute myeloid leukemia, the first question they will ask you is, what is the criteria? Can anyone tell me how many blasts should be present for me call it an acute leukemia? Acute leukemia to call, how many blasts should be there? That will be the first question by default, right? Second, this will be there. The worst come worst, if I need to give you a pass mark, if you tell OR rods are seen in myeloblast, I'm more than happy from an undergraduate, right? If that is also not told, it is tough. It's difficult, right? Let's be honest that that's a bare minimum I expect from you. OR rods are finding seen in myeloblast. And to call it an acute leukemia, I should have more than or equal to 20% blast in peripheral smear or in the bone marrow. It could be either or to call it an acute leukemia, right? More than or equal to 20% is acute leukemia. You're right inside, more than 30%, but please in an Viva, stick to less information. The moment you put the term fab, you are unwantedly poking the examiner to ask what is fab, right? Little bit less. After you come out of the Viva, let's explore and tell the world my knowledge. In a Viva, we are always have to downplay, right? High NC ratio, prominent nucleoli, good amount of cytoplasm tells me it's a myeloid blast, so it's a myeloid leukemia. What's an R rod? I'll tell it's an R rod. See, the next question is what is an R rod? R rod is nothing but a granule in the form of a rod. That's all. It's an acidophilic cytoplasmic granule. That's it. It's formed by fusion of the primary granules of the neutrophils. That's all, right? Normally, neutrophils, they are granulocytes. They'll have granules like this. These granules, when they are fused and forming a rod, we call it an R rod. Actually, there's one more structure called a 5-body. Right? If you answer well, they may ask you this. 5-body is also primary acidophilic granule, but they are very prominent inclusion. Let's assume there's a big granule like this. That we call it as a 5-body. Fine? Okay? Okay, great insight. Your professor must be still living in his own era. When he did a pathology, PG, FAB was very prominent. These days, no one knows about FAB. No one even bothers about FAB, right? If they ask, tell. FAB will be 30%, WHO is 20%. But WHO has been used from the time I did my BBS, right? So we'll stick to WHO, okay? So now I know it's R rod is there, but R rod, you might accept as a rod, I might not accept as a rod. You might say granule present, I might not say granule present, right? So I need markers for sure. The best marker for me to tell is MPO. Myeloperoxidase is a very, very specific marker to tell its myeloid differentiation. That's something which is very important. Don't forget it, right? Okay. There are multiple subtypes of AML. But there's one subtype of AML, that's the next question, which can cause DIC. Can anyone tell me what's a subtype of AML which can cause DIC? There's only one subtype of AML which can cause DIC. What's a subtype? Again, this is FAB subtype. In the WHO, we put them into recurrent cytogenetic translocation. That's your classical APML, acute promyelocytic leukemia, or in the FAB, your AML M3, the old classification of AML M3 and or APML, right? The moment you ask APML, there'll be few questions which will be followed by default. Translocation 1517, PML RARA, and I don't require here 20% blast, right? I'll have lots and lots of atypical promyelocytes. This atypical promyelocytes have abundant granule. That's the reason when they rupture inside a blood vessel, they cause endothelial damage and trigger the disseminated intravascular coagulation, right? Last but not least, just to check your knowledge, can anyone tell me what's the treatment given for APML? Treatment modality given for acute promyelocytic leukemia. Whatever comes to your mind. It is not chemotherapy. Here we use ATRA. ATRA or arsenic trioxide or a combination of both. ATRA is all-trans retinoic acid. That's the treatment for APML. And this is one of the leukemia with almost an amazing prognosis. Literally, we can cure APML if diagnosed before DIC. Because the moment DIC comes, prognosis definitely drops. You know that for a fact, right? Okay, now this is an acute lymphoid leukemia. See here, if you look at this blast versus this blast, the cytoplasm itself is a clue. Good amount of mature cytoplasm, I think of myeloid. Very thin rim of cytoplasm, I think of lymphoid. Because normal lymphocytes also have very thin rim of cytoplasm, right? Now let's look at a slide and then let's come back to this. An acute lymphoid leukemia, you go to the metadab under the 3D library, everything here is marked for you. Okay, look at that, look at that, look at that. It's extremely, extremely dark, very, very, very condensed chromatin, right? Chromatin wise, very condensed chromatin, and you can see that there's almost no cytoplasm at all. It's completely blast-like, right? It's full of blast, very thin rim of cytoplasm, classical for your acute lymphoid leukemia. And one more important thing, this is very favorite for your HODs. The person who asked FAB classification will definitely ask this also in Viva, right? Can anyone name this cell? For me, really it doesn't matter because I'm going to diagnose leukemia with flow cytometry, not even with peripheral smear. I'll say it's leukemia, do a flow say lymphoid or myeloid or biphenotypic. But this is very important for your HODs. That's a hand mirror cell. Look at this. Look at this. Look at this. These are called as a hand mirror cell, where you have a cytoplasmic extension. That's very important finding seen for acute leukemia. Not these days, but definitely for older people, right? Because they used to say it's a lymphoid leukemia with the hand mirror appearance. Which part, Krishna? Tell me which part you didn't understand. I'll definitely explain to you, right? So you have a tiny projection of the cytoplasm. It looks like a hand mirror. We call them a hand mirror cells. That's diagnostic of an acute lymphoid leukemia. Fine, perfect. Do remember them. Okay. Identification points. Same. I have numerous blasts in the peripheral smear. How do I know it's a blast? More than 2 times size of an RBC, it's a blast. I have high NC ratio, a granular cytoplasm, and very inconspicuous nucleoli. And the most important thing is, I want you to remember this: a condensed chromatin. A very condensed chromatin, blue chromatin, hardly any nucleoli. Fine. Okay, come back soon. Zulfikar, soon. After completing 2 sessions of practical, I'll definitely take bone endocrine CNS FARRE. Okay, I'm not leaving it. Okay, ALL is definitely much more common in children. It's one. If I say child with a leukemia, in a long answer question also, you think of ALL only. Fine, and which is positive for lymphoblast. TDT is positive for lymphoblast. There's one more stain I want you to remember: PAS, but dot-like positivity. Dot-like positivity is classical for this. Fine. Okay. That's classical for your lymphoblast. MPO is for your myeloblast. Do remember them, right? Sure, Krishna. I'll talk slowly. Okay. See, this also is important. Extramedullary involvement. Outside the bone marrow, where all your blast can be involved in case of an ALL. That is very, very important because this determines the prognosis. If any question has CNS involvement, testicular involvement, this means it's a bad prognostic marker. Why do I worry about these 2 organ involvement? The reason is simple. These 2 organ involvement anatomically, right? They have a barrier, blood-brain barrier and blood-testis barrier. So they are privileged sites where, sure inside I'll tell you, where your chemotherapy cannot go inside and kill the blast. So I give a chemotherapy, all the blasts in the blood, bone marrow will be destroyed. But these blasts will not be destroyed. They'll come back again after stop chemotherapy. So they are worst prognostic signs. Okay. So these 2 organs are very important in extramedullary places, right? So what is dot-like positivity? So if you do a PAS for a lymphoblast, there'll be a positivity here, tiny dot-like, 1 or 2 dots will be there. Why do I have this dot-like positivity? Because you know that PAS is positive for glycogen. Lymphoid blast is an inactive blast because lymphocyte is not an active cell. B lymphocyte becomes a plasma cell, becomes active. T lymphocyte becomes TH1, TH2, TH3 and becomes active. So lymphocyte itself is an inactive cell. Lymphoblast is also an inactive cell. So an inactive cell has to store its energy. They store in the form of glycogen. So this glycogen will be positive like a pocket. That's called as a dot-like or a block-like positivity. That's for a lymphoid cell, an inactive cell, and a seen in lymphoblast. Is that clear? Okay, perfect. Done. That's for your acute lymphoid leukemia. We saw AML, we saw ALL, and we saw 2 more RBC disorder, anemias, right? Now, this finding. Whenever you see a smear, an image, or in a slide, multiple differentiation. Mature, slightly immature, most immature, and also basophils, eosinophils, everything will be poor, right? That's what they called an college girl appearance or an garden party appearance. In simple words, they are not the same. That's all. In a party, there'll be different types of people. In a college, there'll be different types of people. They don't look uniform. They are not the same. We call it a CML, very classical finding for chronic myeloid leukemia, right? I think we have slides of CML also in the Meded app. Just let's go and have a look at it. If it's there, let's see. Yes, we do have. The goal is simple. Everything is there in general pathology inside. Fine. See, if you look at this, look at that. You do have multiple cells here. I have a very immature blast. I do have a maturing band form. I do have a neutrophil also, right? Look at this. Can anyone tell me what this is? That's a degranulated basophil. You can look at the very bright blue granules, right? That's a basophil. I have a blast. I have a maturing cell. I have immature cells. All of them. Again, this is a degranulated basophil, right? This is an NRBC. So when you have all these maturing stages, the first thing which comes to my mind is chronic myeloid leukemia. By default, it has to be a chronic myeloid leukemia. So how do I know? What are the identification points? You have to have this word in your paper or in the Viva. Cells of different stage of myeloid maturation is seen. Can anyone tell this entire thing in one word? If you have to call it in one word, I use the term neutrophilic left shift. That's it. Or shift to left, right? So when you have different stages of myeloid maturation, I call it neutrophilic left shift. I'll have increased metamyelocyte, I'll have blast, I'll have promyelocytes, myelocytes, everything will be increased, right? So the word an examiner is looking for is shift to left or a left shift. Anything is fine. Left shift, neutrophilic left shift is diagnostic of a CML, right? And this guy, basophilia is very, very characteristic. They will definitely ask you chromosome, and I'm sure this one chromosome you will never forget throughout life. That's translocation 922 BCR-ABL1 fusion gene, fine? So what is Philadelphia chromosome? See, generally what we know is we call Philadelphia chromosome CML is Philadelphia. Actually, CML is not Philadelphia. Translocation 922 is not Philadelphia. What is Philadelphia is the shortened 22nd chromosome after the translocation is termed as Philadelphia chromosome, right? If they ask you what is Philadelphia chromosome, it's not translocation 922. Because of the translocation, let's assume this 22 is 9. It is translocated, fine. Because of this, one has become bigger, the 22 has become smaller. The shortened 22 is called as Philadelphia chromosome with respect to CML, right? Perfect. Okay. So CML, the most important thing in CML is I don't want marker, I don't want bone marrow biopsy or aspirate. We do everything on peripheral blood, and I do a FISH or a PCR to diagnose or to confirm CML, the same translocation, right? I have to treat. Can anyone tell me what's a drug given for CML? I'm sure you know that. Tell me the drug which is given for CML. We have one very important drug which targets the core pathogens of CML. That's a BCR-ABL translocation, which is imatinib. Imatinib is a tyrosine kinase inhibitor. Because the ABL gene, as a proto-oncogene which gets activated, will activate tyrosine kinase. So it's a tyrosine kinase inhibitor which is given for CML. What if I don't give the drug, or even if I give the drug, what will be the prognosis or progression of CML, right? This will bring the phases. Chronic phase is where I diagnose them with. It can move to accelerated, it can move to blast crisis. That's how everywhere the progression of CML has to be. It's inevitable. If I give the treatment, might happen in 20 years. If I don't give the treatment, might happen in 5 years. It will progress from chronic to accelerated to blast crisis. Can anyone tell me how do you identify blast crisis? One feature to tell me, okay, the CML in blast crisis. What's the feature? What's the cell you look for? Remember easy ways. Blast crisis means it is not chronic leukemia anymore. It has become an acute leukemia. That's what blast crisis is, right? So more than or equal to 20% blast in the peripheral smear or bone marrow, or I see extramedullary blast like a chloroma. I see outside the bone marrow, I see blast, I call it a blast crisis. Blast crisis is equivalent to it has become an acute leukemia. Can be acute myeloid or can be acute lymphoid, right? So that's what blast crisis is. And the moment blast crisis happens, the prognosis drops like anything. Fine? Yeah? Perfect. That's a fifth slide. Let's go. Look at this. I'm underlining a cell. I want you guys to tell me what are these? What are these cells? There are few cells which have marked them. Can anyone tell me what these cells are? That's the first question, right? Next, my cell of choice is this. Okay? This is a cell which I'm interested in. Can anyone tell me, is it a blast or not a blast? That's enough. Because we always diagnose based on the keyword. I can diagnose with others also. That's not a eosinophil football lover. That's a smudge cell. It's a destroyed cell. It does not have a nuclear membrane. And this cell which I have marked is not a blast because it is equivalent to the size of an RBC. So it's a lymphocyte. Got it? So this is a lymphocyte, and I have increased destroyed cells called smudge cells. So my diagnosis, I'm sure everyone knows it, diagnosis chronic lymphoid leukemia, right? I'm sure you'll be able to diagnose. See, smudge cells, what you have seen in the image might not look the same. Not every smudge cell will be the same. It will look different. This is not a blast inside because the cell is equal to the size of the RBC. It should be more than 2 times for me to call it a blast. Fine. Let's look at a smart cell from our Meded app. If we have them, I think we should have them. Yeah, let's see if it's there. So not all smears will be the same what we see in Google, right? That's a smart cell. Okay. Come back soon, Prem Saini. That's a destroyed cell. That's a smart cell. How do I know it's destroyed? Look at this cell. It has a cytoplasm. It has a very defined nucleus. That does not have a defined nucleus. It's a destroyed cell. That's a smart cell, right? Look at this. That's a smart cell. Because of vimentin, the cytoskeleton will be lost. So the cell becomes very, very fragile, and that's a smart cell. Fine. Okay. Now someone asked me one more question. This is a very dark, look at this. This might help me to explain that. I'm not sure if you'll be able to appreciate it. But this nucleus, if you look at this nucleus, I do have dark areas as well as I do have a little bit of light areas, right? Light area, light area, light area, dark area. This altering light area and dark area gives the appearance of a football. So they call it a football chromatin. The chromatin looks like a football. Not always you'll appreciate that. It's based on the staining. If it's a dark stain, I won't be able to appreciate them. But the smart cells are a diagnostic of the disease, that is chronic lymphoid leukemia, right? Here also it's not very evident for me to call it a football like chromatin, but if I zoom this, you will accept that somewhere it is light, somewhere it is dark, right? This altering light and dark area gives the appearance of football. Let's say if it's a football, I'll have dark light areas, right? It looks like a football, so we call it a football chromatin. Fine. That's a name given to it. I think someone asked me that. That's the answer. Fine. It's okay, real Z. Fine. We'll learn from now on. No issues at all, right? So we have absolute lymphocytosis. This is the word I'm looking for. If you have more than or equal to 5,000 cells per cubic millimeter per ml, and these 5,000 cells should be clonal, which means they have to have the same CD markers. Because a viral infection also sometimes might have more than 5,000. Absolute monoclonal lymphocytosis is very important for me to identify it's a CLL. That's one. And predominant of small maturing lymphocytes. It should be small. It should be mature lymphocytes. That should be more, right? And clumped chromatin. The clumping is what makes the dark area, non-clumped area, light area. That gives us football appearance. And like we saw, smart cells. Smart cells, absolute lymphocytosis, diagnostic of chronic lymphoid leukemia. Generally seen in elderly person, the history will be simple. 40, 50-year-old, and you'll have generalized lymphadenopathy. And if it's coming in a long answer question, do remember there's a possibility that CLL very frequently can be associated with autoimmune hemolytic anemia, and ITP, immune thrombocytopenic purpura, is a common associations of CLL. Fine. Why is this much happening? They are fragile lymphocytes. Why are they fragile is also a question, right? Because of vimentin loss. Because of vimentin loss, they become fragile, they become disrupted, and then we call it's just breaks when I make a smear. So every leukemia lymphoma is diagnosed based on CD markers. What are the classical CD markers for CLL? If someone asks you CD markers, it is difficult to memorize everything, right? So you need some time to think. But in a Viva, the timing is very important for me to answer. Keep a template. Myeloid, MPO, remember. Lymphoid, PAS, remember. CLL, Burkitt, your follicular, your mantle, everything are B-cell lymphomas. So without even thinking about it, tell a B-cell marker. Okay, CLL tumor, it's a B-cell lymphoma. So they are positive for 19 and 20. So this is something which will immediately come to my mind. And then they are also positive for 5 and 23. These are diagnostic marker. Mantle, it's a B-cell lymphoma, positive for 19 and 20. Meanwhile, think that, okay, mantle cell lymphoma will have translocation 11, 14, just cyclin D1. Cyclin D1 is diagnostic. Follicular, it's a B-cell lymphoma, positive for 19 and 20. Follicular lymphoma mutation is BCL2. It's also positive for BCL2, right? The key one, if it takes time, use the template. Filler, that's all for time. Take time, think and answer. Because this will never go wrong. Every B-cell lymphoma will be positive for 19 and 20. No one ever can tell it wrong. Fine? Okay? I'll ask them to have a look at it. Sari Ahmed. Fine? Okay. Now, let's look at few of the histopath slides. Fatty liver. Something which every undergraduate can identify. right? Very easy one. You don't need to look at the slide outside or the number to identify fatty liver, right? So now, if I am the examiner, I won't worry about fatty liver. I'll ask you a simple question. How did you identify it as a liver? Tell me that first. We'll go to the fatty liver second, because identifying liver is important for me to call it a fatty liver, right? Because fat is clear. Everyone knows that. What if fatty changes the heart or kidney? How do you identify the liver? If someone asks, is like me irritating and tells you like, how do you identify the liver? Simple. Liver will have portal triad. Look at the beautiful portal triad. It will have artery, vein, and the biliary radical, right? I'll zoom it further if let's see. Okay, perfect. Biliary radical, artery, vein. That's a portal triad, right? Liver will have portal triad. Plus, I have rows of hepatocyte. That's a beautiful architecture of liver. I have hepatocyte, sinusoid. Hepatocyte, hepatocyte, sinusoid, hepatocyte, sinusoid, hepatocyte. That's rows of hepatocyte, right? I have rows of hepatocyte separated by sinusoids, and I have beautiful portal triads here. That tells me it's a liver biopsy. Then, in quite a few of the hepatocytes, actually, if I can tell, in the periportal area, that's very accurate. In the periportal area, lots of hepatocytes have clear vacuoles, so I call it a fatty liver. That's a very simple, easy description of a fatty liver. Fine. Steatosis. That's all. Fine. Okay. Perfect. How do you identify this steatosis? Simple. It has clear hepatocyte vacuoles. Predominantly, what you see in the image are macrovesicular steatosis because they are single large vacuoles pushing the nucleus towards the corner. Yes. If it's a single large vacuole pushing the nucleus to the corner, I call it macrovesicular. Microvesicular is nucleus will still be in the center. I'll have multiple tiny vacuoles surrounding the cell's nucleus. We call it microvesicular. Most of the time, severe cases will be macrovesicular steatosis only. The moment you tell fatty liver, because of the clear appearance, they'll ask you why it is clear vacuole. This is like a template, and they are used to it. They have been asking every time, every once in 3 months, Viva, they'll ask the same question. You cannot change the questions at all. Lipid will be dissolved by solvents which is used during processing. So lipid gets washed away. So what I see in microscope is an empty space of cytoplasmic vacuole because lipid is getting washed away during processing. That's all. Okay. Cause of fatty change. Tell 2 causes. Remember 2 causes enough. Alcoholic liver disease, non-alcoholic fatty liver disease, which is metabolic. That's enough. That's more than enough. Alcoholic, metabolic obesity syndrome is more than enough. Rest everything are all extra pointers, but these 2 are something that is very important for me. Drugs, toxins, hypoxia, hepatitis, lots of them cause fatty liver. But alcohol use, non-alcoholic fatty liver disease, metabolic syndromes are the most important, 2 important causes of fatty liver. Fine. Okay. Then if it is clear, how do I differentiate fat from water? Water is also clear. Mucin is also clear. There are 2 important stains. I have oil red and Sudan black, and please don't let them ask the next question. You yourself tell. Fat can be demonstrated using frozen section, not in a routine section, because routine section is washed away, right? In a frozen section, I use oil redo and Sudan black to identify fat because in frozen section, they are not being washed away. Fine. Okay. That's a simple case of fatty liver. Clear? Perfect. Let's see. I hope you have not seen the heading. Can anyone tell me what's a diagnosis here? Might be a difficult one, but let's see if you're able to identify them. Because there's a very important clue here. What's a diagnosis? Can anyone tell me the diagnosis? There's a very important clue. If you want, I'll tell you the clue also. This is one of the important clue here. This secretion is seen in the lumen of the gland. That tells me what organ it is. Okay. I'll give you one more clue. The secretion is called as corpora amylaceae. Still tough? Okay, that's a great insight. That's a classical slide or a picture of benign prostatic hyperplasia or a benign prostatic hypertrophy, right? It's BPH. The ideal term what we use now is, we call it benign prostatic tissue. That's all I call it. I don't use the term H at all. It's benign prostatic tissue. How do I call it benign? That's my only concern. I don't care it's hyperplasia or hypertrophy. I am worried about it's benign or malignant, right? Like someone said, I can see the myoepithelial cells. If you can see this, I have a cell here, right? I have a cell here. I have a cell here. That's my luminal epithelial cell. At the same time, you can see in the behind, In the background, I have flattened cell, that is myoepithelial layer. You can see there are two cells here. The two layers tells that my prostate glands are benign. I need to have a luminal epithelial cell and I need to have a myoepithelial cell. You can look at every gland here. Look at this. I have a very flat, dark myoepithelial cell and a elongated columnar epithelial one, right? So if I see two layering, I can 100% call it as a benign gland. This is true for both prostate and breast parenchyma. Do remember them, right? It's very, very important. If it's preserved, I call it a benign gland. And corpora amylaceae is a clue. I can have these structures. I won't exactly able to call it benign, but they are most likely seen in benign condition, not in neoplastic condition, right? I'll see if I have slides here. This is not there in the Medit app. I hope it opens and I hope we'll be able to see them. These are our slides. The internet sucks. Okay, it's not opening. Fine. Apologies for that. Okay, let's look at the question. If it opens, I'll share the slides with you guys, right? I have nodular proliferation by definition. The most important thing, I require these two. I have both glands as well as stroma is proliferating here. It's not only glands, it's both glands and stroma. Glands can be of various shape, but this is very important. I can call it myoepithelial or I can call it basal. I should have both luminal cell as well as myoepithelial cell. It's very, very important for me to call it a benign prostate tissue, right? The most common zone is the transitional zone. Prostate has the peripheral zone and close to the urethra and a transitional zone. The transitional zone is where BPH is very common, or we call it a periurethral zone, right? And the reason, the most important cause of BPH is dihydrotestosterone. Testosterone gets converted to DHT. DHT is the most important driver for the proliferation of the glands and stroma. So now, if I have a way to stop testosterone becoming DHT, so there's a good way I can reduce or halt the growth of BPH. Yes, no, maybe. Yes. Testosterone becomes dihydrotestosterone and DHT is the most powerful stimulant. So there's an enzyme which does that. Can anyone tell me a drug? You must have read in pharmacology 100%. A drug which will stop the conversion of testosterone to dihydrotestosterone. What is the drug? It's an alpha reductase. 5-alpha reductase is the enzyme which transfers them. So I block the enzyme. That is, I think it's finasteride, right? You know the drug. We have drugs which will stop the conversion of testosterone to dihydrotestosterone. So it reduces symptomatology of BPH or prevents the further growth of BPH, which is very important. You have to know because it's an application. That's all. What will be symptoms of BPH? I have a urethra here. Surrounding I have prostate glands. So the prostate glands keeps on multiplying more and more and more and more. The urethra becomes very much narrowed. So the flow of the urine will not be normal. So I have hesitancy, poor frequency, urgency, everything. Because of the urinary retention, there's a possibility of increase of infections also. So frequency, urgency, incomplete voiding or emptying of bladder is one of the classical symptoms of BPH and age. Fine? Yes, for that also. Fine? Okay. So for all these, we will be the symptoms of benign prostatic hyperplasia. One important thing which I want you to remember. We always read as a template. We say that hyperplasia is there, which will cause cancer. But please remember, BPH is something which does not progress to prostatic carcinoma. Everywhere it progresses, hyperplasia progresses to carcinoma. Here, it does not progress to prostatic carcinoma. This gland will not become malignant, but the same prostate can have malignancy. That's different. But this gland will not progress to malignant. Like an endometrial hyperplasia will become endometrial adenocarcinoma. It's a precursor lesion, but BPH is not a precursor lesion for a carcinoma. Remember them because it's outside the template. You might forget them. Fine. Next, fibroadenoma. Let's see if these slides work. Initially it worked, but now okay. At least something worked. Fine. This is a classical case of fibroadenoma. Low power fibroadenoma looks like that. Look at them. The compressed duct is classical for fibroadenoma. You have fibroadenoma. So fibrous component and adenomatous component increase, right? So these fibrous components are very thick. So they compress the adenomatous component. Here it is not compressed. Looks like a normal duct. But here it's compressed completely. It's compressed completely, right? This is stroma. It's become hyalinized here. It's compressed here. That's a classical finding, compressed. The gross of fibroadenoma will have slit-like spaces. This is a slit. The compressed gland is a slit, which I can see in gross. When I do an FNAC, this compressed gland comes outside. We call it antler horn. Looks like a horn appearance, right? So that's classical for fibroadenoma. When you have compressed glands and when you have stroma surrounding them, like this image, we call it a fibroadenoma, right? So fibroadenoma is a well-phased biphasic tumor. Again, same. Like your BPH, I have both proliferation of duct as well as stroma. And the most important thing is this. It'll be compressed like slit-like spaces. This is very, very classical for fibroadenoma. Does the pericanalicular intracanalicular pattern really make sense for me? No, it doesn't make sense for me. Right? But if they ask you, tell there are two patterns which has no prognostic significance. No one reports them in real life. Fine. It's one of the most common benign tumors and it's very, very, very mobile. So we have an analogy called in breast mouse. Let's not use it. But it's a very mobile tumor which is seen in young individuals. Fine. It's a benign fibroepithelial tumor. Actually, phyllodes is not an important differential diagnosis because phyllodes will be very huge. But very early phyllodes will be small, right? It cannot just like that become big, right? So slowly it grows. So in early onset, one of my differential diagnosis is phyllodes. That's all, fine? Okay. So fibroadenoma is a very simple finding. Please remember them. And gross will have the same finding. It will have the slit-like appearances. And microscopy, in FNAC, we have finding called an antler horn appearance. All the compressed slide, when I pull them, look at this, it actually looks like a horn, right? That comes out in the cell. In FNAC, I have an antler horn appearance. That's classical for a fibroadenoma of breast. Fine. Perfect. Let's go to the next guy. A simple spotter. These you cannot miss. You don't want the slide number to identify. Look at that. So much big spaces filled with RBCs. I'll zoom in. RBCs, huge cavernous spaces. Spaces are cavernous, right? Cave-like. Cavernous spaces filled with RBC. I can see them anywhere. I call them cavernous hemangioma. Yes, I do have septa in between. Some might be thick, some might be thin, right? That's a classical case of a cavernous hemangioma. Look at the beautiful thing, right? This is actually seen in the subcutaneous location. You can see skin here. Subcutaneous is one of the commonest places of cavernous hemangioma. Fine, okay. Now, how do I know it's cavernous hemangioma? For Viva or Tried, very large dilated vascular spaces lined by flattened epithelium is fine. They are almost always filled with blood and have intervening connective tissue. Okay. First question. Can I see cavernous hemangioma in internal organs? Yes or no? What do you guys think? You guys have been awfully quiet. So tell me the answer. Can I see cavernous hemangioma in internal organs? Like liver, like kidney? Can I see them? Yes, absolutely. Can I see them in skin and subcutaneous? Yes, absolutely. If I see cavernous hemangiomas in organs, what will I think of? Will I think of sporadic or syndromic? If it's syndromic, what syndrome? At least remember one syndrome. Cavernous hemangioma can be seen in internal organs like liver. It's one of the commonest tumor, hemangiomas of the liver, right? If I see in internal organs, liver, spleen, GIT, anywhere, in multiple places, I think of syndromes. VHL syndrome is one of the places where it's commonly seen. Multiple cavernous hemangiomas in internal organs. Think of one Hippel-Lindau syndrome, right? Please do remember them. Something which you have to answer, fine? Okay. What is an hemangioma? It's a benign neoplasm. That's all. I have two types. We have capillary hemangiomas and we have cavernous hemangioma. Okay. How do I differentiate is the next question. Capillary, right? Capillaries are tiny. You saw the space. That is not capillary at all. Capillary hemangioma will have numerous capillaries. That's it. Multiple tiny capillaries which will be very, very, very close to each other. We call it a capillary hemangioma. Please remember, if you have a slide of capillary hemangioma in your college, it will be very, very similar to granulation tissue. Granulation tissue also will have multiple tiny capillaries. It will look the same. Cavernous is a spotter. Capillary needs some time to identify, right? It will have multiple tiny capillaries, will look like a granulation tissue. That is capillary hemangioma. What else can be differentiating point? Capillary hemangioma is very small, red in color. Cavernous hemangioma can be large and bluish in color. Capillary hemangioma most of the time resolves. It's seen in children commonly. When the child grows, it automatically resolves. Cavernous doesn't resolve. I need treatment, right? So what could be complication? I can have hemorrhage. Yes, definitely. I can have thrombosis. Can anyone answer Why does cavernous hemangioma have thrombosis? Again, it's linking general pathology to systemic pathology, that's all. Right? It's a huge place. Yes, if there's a trauma, it can bleed out for sure. Hemorrhage is possible, thrombosis is possible, ulceration very much possible because both hemangiomas, capillary and cavernous, are unencapsulated lesion. Though they are benign, they are unencapsulated lesion. Both capillary as well as cavernous can have ulceration, right? Let's come back to the question that you asked. Huge space of blood. Can I have stasis? Definitely. Does it alter Virchow's triad? It does. That's all. Every answer comes from general pathology. Stasis, which alter Virchow's triad. So obviously, I'll end up in having thrombosis. As simple as that, right? Simple things. Do not complicate medicine. Medicine is simple based on logic. You know the logic, you can apply throughout the body. Fine? Perfect. Now, let's go to one more guy. I hope this opens. Seminoma, desgeminoma, both are same. Fine? Great. Okay. The first and the foremost thing, these are your epididymal linings. Okay. Here, I have a lesion which is kind of infiltrated. It is not capsulated. You can see that, yes, it's kind of infiltrating here, right? Okay. Let's zoom in further. Let's zoom in further. I must have marked it somewhere. Let's look at that area only, right? Here, if you see, I have septa here. I have tumor cells arranged between the septa. We call this nesting of tumor cells. Look at that. I have a septa here. I have a septa there, right? Septa. It's tumor cells arranged in nests. And the most striking feature is it is clear because of glycogen. Clear tumor cells arranged in nests separated by septa is classical for seminoma. And one more very important finding, what you can appreciate here is this is very classical for seminoma and dysgeminoma. The septa will have infiltrating lymphocytes. I hope you can appreciate that. There's a septa here. There's also the septa there. You can have infiltrating lymphocytes inside them, right? Infiltrating lymphocytes, clear tumor cells, arranged in nests is classical for seminoma, classical for dysgeminoma also, right? Very, very classical finding for both seminoma and dysgeminoma, right? How do I identify? Very important. This will definitely come in a Viva. Why are they clear? Fine. Yes, I can see your message inside. Amazing answer. What's the straight answer to stasis? Fine. Okay. So prominent nuclear doesn't matter. Lymphocytes in the septa, clear cells with glycogen is what is important for me to diagnose them, right? I can see granulomatous reaction. It's fine. That's not important. Clear cells in nest separated by septa with lymphocytes. Same finding for both seminoma and dysgeminoma. Fine. Okay. Counterpart in ovary is dysgeminoma. What are the IHC markers? See here, if your examiner is old, they are looking for PLAP. PLAP is not something which I use these days. OCT3/4, NANOC, SAL4, enough. PLAP, placental leukocyte alkaline phosphatase, is a very old marker, 50-60% sensitivity. I'm not going to use it. But if you answer OCT3/4, you answer SAL4, you answer NANOC, you answer this, still they are asking something else, then answer PLAP. PLAP is also a marker which we don't use nowadays. Don't go and tell that to them. We don't use it nowadays. You're poking the bear. If the lion or the bear is quiet, let them be quiet. Tell it's also a marker which is used, that's all, right? So one more thing is there any serum markers? Actually, seminoma does not have serum tumor markers. Testicular tumors have LDH. LDH is not specific for it. Fine. Great, Andy. LDH is not specific for the tumor at all. LDH tells the lesion is bigger, smaller, that's all. This correlates with the size of the lesion. If you have a tiny lesion, it's smaller, less LDH. Bigger lesion, more LDH. It does not tell me it's seminomatous, non-seminomatous. AFP is another tumor marker what we use, okay, which is normal in case of seminoma. AFP is elevated in case of yolk sac tumor or non-seminomatous germ cell tumor, right? Beta HCG. These are the only 3 WHO approved markers. No other markers are approved for WHO with respect to testicular tumors. Fine. Maybe after tomorrow also I have a practical class. After that, I'll talk about that. Fine. Okay, Jayesh. Fine. These are 3 approved tumor markers. Seminoma might have, not always, might have in 10 to 15% of the cases, it will be elevated because 10 to 15% of seminoma have syncytial trophoblastic-like cells. Otherwise, beta HCG is a classical finding for choriocarcinoma. You know that, I know that. Fine. Perfect. Now, today's last slide. I don't have a slide for this, so I just put an image here because this is something which might come in an exam. You have sclerosed glomeruli, you have atrophic tubules, the tubules are completely gone, and you have pink color. The tubule is filled with pink color material. That's a classical thyroidization of tubules. The tubules looks like thyroid. Can anyone tell me the diagnosis? Thyroidization of tubules, sclerosed glomeruli, atrophic tubular epithelial cells, and maybe I can see some blue cells in the interstitium. That's lymphoplasmatic cells, cells in the interstitium. Diagnosis? You know the answer. That's a classical finding of chronic pyelonephritis. That's how chronic pyelonephritis looks like. Fine. Okay. So chronic pyelonephritis, what are the identification? Atrophy dilatation, and this word is what I'm looking for from an undergraduate. Thyroidization of tubules. Why do I have thyroidization? When the tubules are destroyed, the function of tubule is reabsorption. Epithelium is gone, atrophied. It cannot reabsorb. So protein gets accumulated inside more and more. So I call it thyroidization. It's chronic, will have fibrosis for sure. Tissue destruction and healing by fibrosis is by default for chronic, right? And obviously, I can have infiltration of lymphocyte plasma cells in the interstitium, but these two are more important for me for diagnosis, right? Thyroidization will have atrophic renal tubules, and the eosinophilic proteinaceous scars looks like a thyroid follicle, so we call thyroidization of tubules. That's it, fine. Where can I see chronic pyelonephritis? These two are precursor lesions are must. Reflex nephropathy could be congenital, right? Vesicoureteric reflex, that's what I call as reflex nephropathy, or some distal obstruction. So urine is not flowing properly, so it goes behind to the ureter, to the kidney, and cause infection. And it has to happen recurrently again and again. Only then I have chronic pyelonephritis. So how do I look at them grossly? Microscopy, okay, thyroidization, chronic, everything. Gross, every time you had a pyelonephritis, there'll be a scar. Multiple, like 10, 20 times I had it. I'll have multiple scars, right? That's very, very classical. When you have coarse, very, very, very ugly, irregular, asymmetric scarring. All these are very important. It should be coarse, it should be asymmetrical, maybe bilateral, maybe unilateral, based on the reflex or obstruction. But they are irregular, asymmetrical scarring, I think of chronic pyelonephritis, right? There's a beautiful image in Robbins, and you can have a look at them for sure, right? That's about chronic pyelonephritis, fine? So today we have seen quite a good number of slides. I'll just have a quick recap. We saw IDA, we saw megaloblastic, AML, ALL, CML, CLL, almost every common basics of lymphomas and leukemias, right? Fatty liver, we saw about BPH, we saw about fibroadenoma, hemangiomas, seminoma, and chronic pyelonephritis. Tomorrow I'll have few more slides, and definitely I'll take FARRE of CNS, bone, and endocrine once I complete them, because they are going in a system, so I don't want to derail it. So once it's completed, I'll definitely take FARRE, so everything will be sorted for your exams, right? All the very best, do well. Practical is something which is in your hands. Don't think that, okay, I've studied, I'll not do good in practical. Viva is an art to answer. The moment you know how to answer, the moment you know how to drag them to an answer, it's more than enough, right? And always, please don't immediately blurt out answer. Think for a second or two and answer. No examiner is going to shout at you, fine? Okay, see you soon, see you tomorrow. Till then, bye-bye.